Hello everyone. Today our group will be discussing gender normalizing intersex surgeries and what arguments there are for and against them. Intersex is an umbrella term used for individuals who are born with genitals, reproductive organs, secondary sex characteristics, hormones, and/or chromosomes that defy gender binary norms. It is estimated that 1.7% of the population is intersex. However, this number may be greater given the culture of non-disclosure and secrecy that characterized intersex healthcare until recently. Differences in external genitalia are often visible at birth, but for some individuals who have non-binary internal reproductive organs, this aspect of their anatomy and identity only becomes visible during puberty. People sometimes confuse being transgender and being intersex. Intersex people are medically recognized for their atypical anatomy or genes, whereas being transgender has to do with one's internal knowledge of their gender identity. There are 4 different categories that together cover all the ways an individual can be considered intersex. Ambiguous genitalia is a rare condition in which an infant's external genitals don't appear to be clearly either male or female. The genitals may be incompletely developed, or the baby may have characteristics of both sexes. For instance, a penis doesn't form or is very small and looks like an enlarged clitoris. The urethral opening may be at the base of the penis instead of the tip, or a small separated scrotum looks like labia. Androgen insensitivity syndrome is when a person who is genetically male is resistant to male hormones. As a result, the person has some of the physical traits of a woman, but the genetic makeup of a man. Some individuals can also have a discrepancy between their external genitalia and internal reproductive organs. And lastly, some individuals have chromosomal variants. Many intersex people don't undergo any kind of medical intervention, such as surgery or hormone replacement therapy. However, for our presentation, we will be focusing on individuals who have anatomical variations and can have surgery. It's important to note that gender confirmation and gender normalizing surgeries are different. Surgical procedures can be broadly divided into masculinizing or feminizing procedures intended to make genitalia more like typical XY males and XX females. There are multiple techniques and approaches to each procedure, and some children receive a combination of them. Some of these procedures are orchiopexy, which is the repair of undescended testes, hypospadias or epispadias repair, which is the repositioning of the urethral opening. This can be done in a single or multiple procedures based on where the opening is. Clitoroplasty or phalloplasty, which is any reconstruction of the clitoris or penis. Reduction or repositioning of the clitoris. Vaginoplasty, which is creating or altering a vagina. Or gonadectomy, which is removal of organs that produce sex hormones.
Until lately, genital surgeries have been considered the norm for intersex individuals. The guidelines for the care of intersex newborns stem from the work of John Money, a New Zealand psychologist that studied sexual identity and biology of gender. His theory was that what is needed for a quote-unquote normal gender identity was unambiguous genitalia, so a penis or a vagina, and full affirmation from the parents as to the chosen gender. This is based on his belief that nurture will overpower nature. A baby born with ambiguous genitalia would be operated on to achieve either a full male or female appearance, and their gender would be reinforced in the home. It is because of his research that there are so many intersex individuals that did not know they were intersex until much later in life. It is important to note that John Money's work is considered extremely controversial in the scientific community. Nowadays, we can group the reasons behind intersex surgeries into 2 main categories: physical health and psychosocial factors. Physical health includes surgeries that are deemed medically necessary. A baby can be born with a urethra that is partially occluded or not fully developed due to the formation of their genitals. This can lead to changes in urination, issues with sexual function in the future, and frequent UTIs. There can also be a fistula or connection between the urethra and vaginal opening, causing urinary incontinence. Sometimes tumors or malignant tissue can also be found in the gonads, and are operated on during infancy to prevent cancer risk. These instances are all deemed medically necessary to preserve the quality of life for intersex individuals. The other category behind intersex surgeries are psychosocial factors. This is when the surgery is an elective procedure that is decided on by the parents and medical team. Many people believe that genitalia needs to match the child's sex rearing in order for them to form a quote-unquote normal gender identity, and in turn, children are socialized into a chosen gender. This stems from John Money's theory that was previously mentioned and current societal views on gender as a binary structure. Parents may find themselves unprepared to raise an intersex child due to lack of information and personal or cultural beliefs. And they believe they are doing the right thing by changing the genitalia of the infant to fit traditional male or female presentation. Although we now know that gender identity is extremely complex, many parents believe that they are still acting in the best interest of their child. Intersex individuals have higher rates of discrimination, physical violence, and sexual assault compared to non-intersex individuals. In this instance, surgeries are performed with the belief that giving the child quote-unquote normal genitalia will protect them in the future.
While we have presented arguments for having gender-normalizing intersex surgeries, our group as a whole strongly believes it should not be performed unless medically necessary. These surgeries have the potential to inflict permanent physical harm, for example, sterilization, scarring, loss of function, and sensation of the genitalia. As you can already tell, the negative impacts that the surgery has on sexual health and function can be both frustrating and devastating when the individual grows older. Undergoing such surgery also requires the individual to be on lifelong hormone replacement therapy, which inflicts additional trauma. There is evidence showing that gender-normalizing intersex surgeries significantly impacts one's mental health. These painful procedures often continue to puberty, which puts the individual at an increased risk for depression and suicide. There are also instances where the individuals come to the realization that they are not the sex they had to conform to because of the surgery, which again leads to depression, resentment, anxiety, and grief. It is often argued that this surgery does not cause a traumatic experience because medical professionals have not heard back from intersex individuals regarding their experience. However, there is growing evidence that satisfaction of parents is combined with the satisfaction of the patients when the patient's satisfaction is actually not considered at all. Although intersex individuals might not be verbalizing their trauma, it makes them hesitant to other medical interventions. For example, they may avoid receiving medical care, dissociate during medical exams, and distrust medical providers due to anxiety and depression, which can be seen through somatic responses such as freezing and muscle tension. Gender-normalizing intersex surgeries violate several ethical principles like autonomy, veracity, and non-maleficence. Intersex surgeries are generally performed on infants and children, and as we all know, we cannot get consent from them. In the event that the surgery is done when it is not medically necessary, it violates the individual's autonomy and also indicates that this procedure is being done without the child's best interest taken into consideration. For that reason, surgery for intersex infants and children should be delayed until these individuals can decide on their own on whether or not they want the surgery. Gender-normalizing surgeries also violates the principle of veracity in the sense that individuals who are born intersex are not told about their history after surgery is done. One of the main reasons the truth is withheld is due to the fact that parents want their children to conform to the assigned sex after surgery and actually believe that they are that sex. In other words, telling the child the truth will prevent the child from identifying with the assigned sex. As discussed earlier, lifelong hormone replacement therapy is given once an individual undergoes intersex surgery. In many cases, the individual does not know why they are taking it, which affects their understanding of this medical intervention and also induces stress. Additionally, because the individual had genital surgeries, they experience anxiety due to the lack of sensation and function and sexual desire, which is why it is important to validate their feelings so that they do not feel alone. This cannot be done if this procedure is not openly discussed between the individual and their parents. The third and final ethical principle I will be discussing is non-maleficence, which means do no harm. If the surgery is done for cosmetic purposes rather than a medical necessity,
Medical professionals are disregarding the Hippocratic Oath because they are performing unnecessary surgeries that will cause physical and psychological harm, which will occur if the individual rejects the sex assigned to them.
So, what are some of the things intersex people want us to know about their experiences as patients? What should we bear in mind as we begin our RN careers? The first and most important is that we will all have many intersex patients. If nearly 2% of the population is intersex, that means if we work in a high volume unit, such as the ED or a primary care outpatient clinic, we'll have intersex patients every week. And even if we work in the ICU or another part of healthcare seeing far fewer patients at a time, we'll still have intersex patients statistically more often than we treat redheads, people living with HIV, or people with glaucoma. That said, most of the time, a person's external genitals, internal sex organs, or hormone levels will be irrelevant to the care we'll provide. For example, a genital check is completely inappropriate when giving someone a vaccine or working them up from a possible MI. And yet, intersex people report excessive, invasive, and ultimately abusive treatment by providers all the time, quote unquote care that amounts to battery.
As you can see, there is so much that goes into making the decision to go forward with or forego gender normalizing surgeries. While we can't make the decisions for our patients, it is our duty as nurses to make sure that our patients and their guardians are well educated on their options. As nurses, we are to be lifelong leaders, meaning that we expand our wealth of knowledge as the world evolves. As nurse leaders, we are to spread that knowledge with patients and colleagues alike, especially when there's a noticeable gap. Once our patients have fully understood their options and have made the decision, we must advocate for them. We are to rally behind their choices, especially when they aren't present to do so themselves. For example, if the surgeon is making a choice to go against the guardian's wishes after the guardian has been educated, consent forms have been signed, and the patient is on the table, it is our job to speak up for that patient and call out the wrongdoings of the surgeon. Lastly, we are to model accepting behavior and respectful language. It goes without saying that we are to lead by example. Once the guardian has made the decisions, we must model acceptance and be respectful of the choices made. In doing so, we will set the stage for how others interact with the patient and guardian, which will in turn remove the stigma associated around gender-confirming surgeries in intersex populations.
It's difficult for intersex people to find each other because from an early age we're told not to talk about our bodies.
I did feel like I was the only one.
My doctors always told me there was nobody else like me, and so it just perpetuates a vicious cycle of shame and stigma that we can't break out of. I would tell another intersex person that you are worthy, you are lovable.
Your body is beautiful, you're beautiful.
Intersex people don't need to be fixed. There's nothing wrong with them.
I know you feel like you might not be able to get through this. I know you might have really dark thoughts, but I want you to know that meeting other intersex people and finding a community or a support group can be one of the most important aspects in your healing process. And we're out there, we're out here, we're here. And I just hope you can find us.